Hello, everyone. We are going into chapter 12, respectful interactions when the patient is dying. Whoops, I'm sorry. Let's get into the slideshow. So understanding the 5 stages of death, the Kubler-Ross model, describe the different responses to death, learn about palliative care, and learning how to say goodbye. Really, death still remains the ultimate mystery, and dying is first and foremost a personal experience. I don't think any of us will really know how we would respond to our own death diagnosis unless we're put into it. And it really starts to give you different fears and different concerns on what's happening. And sometimes, depending on culture or religion, that can change the way you react. For some, it can put your affairs in order, meaning your personal or financial affairs. In the Western culture, or Western fairy tales, the death only happens to the bad guys. Or some people may bury, some may cremate, some might wear some others' ashes. So really, some might think reincarnation, some believe in heaven and hell, and really everyone's experiences their own personal one. These are important to know, the 5 stages of death and dying: denial, anger, bargaining, depression, and acceptance. So denial is declaring something to be untrue. We don't believe it. We're not going to believe the diagnosis. I don't want to know what it is. It's just sort of a form of denial on not wanting it to happen. There's anger, which is a strong feeling of annoyance or displeasure. Bargaining. We start to negotiate our feelings. Well, if I can have 3 more weeks with my family, I promise I will pray every day. Just bargaining that aspect of not dying. There's depression, which is feelings of severe sadness or dejection. So you start to become depressed because of the diagnosis. And then finally, there's a stage of acceptance, which is an action of consenting to receive or undertake something. That's just accepting really what the diagnosis is. Some responses to death and dying. And we'll go over 6 of these. The anticipation of future isolation. The patients start to fear that they're going to be separated from their family, their home, their routine. They start to have a gradual loss of habits. They're not able to do the things they normally would. They start thinking that the family's starting to ignore me, or my friends are starting to ignore me. My family's too busy with other things to help care for me. Some relatives and friends might disappear. Make sure that you are giving your own support. The prospect of pain. You start to become anxious, depressed about it. What exactly is what is it going to feel like? Your anxiety and depression can heighten pain, but your reassurance and presence, compassion, and caring can help decrease some of your patient's suffering. There's also a resistance to becoming dependent. These outer limits, or what the book calls it, what one could bear. So, meaning the loss of bowel or bladder, the capability that you can't feed yourself anymore. So think about what your outer limit would be. What would be the last thing that you would want to give up? I think for me it would be being able to go to the bathroom by myself. I think that would be on my outer limit. Reckoning with what death might mean. For some, it could be reincarnation. Hinduism proposed that death is a process of birth and rebirth. In Islam, one may be transported through several levels of paradise depending on the type of life that you lived, which actually sounds kind of nice. Some has resurrection of souls only. Some think that the actual human body will be restored in an improved form. So everyone has a different death and dying experience. I took a death and dying class last term, and it was interesting. And really, one thing that I found that the class kind of kept circling back to is that if we're not enjoying what we're doing now, and we worry so much about death, then we're not living, which I'm sure that you guys have already heard before. But coping responses by patients. That can have many forms. So if you think about the 5 stages that we just talked about, denial, anger, bargaining, depression, acceptance. To many, that first shock is the first response is shock or disbelief. You start to go into denial, followed by it sort of runs that same path, but that doesn't happen just once. You can cycle through these stages over and over. You can go to different stages in different orders. Your patient's personality will change a little bit depending on how they respond. That's okay. That's expected. But understanding that your patient's response will be different depending on how they're feeling. It could be different day to day. It can be different week to week. It's hard. Coping responses by the patient's family. They too go through their own coping responses. And also the diagnosis of a death diagnosis, or you find out your family member is dying. Bring out the best and the worst aspects in a family when someone is dying. Most families are brought closer with the experience, but it can really go either way. Sometimes it can push family against family. I'm sure that we've seen this before. I know that I've seen it in my own family. But typically it's brought in with a closer response. Why is it important to have family there? Well, there's 4 reasons. It allows them to cope more effectively with their stresses. The anticipatory grief, parallel symptoms usually seen in acute grief, but follows death. It can be a sigh, weakness, loss of appetite. You're sort of anticipating what's going to be happening when it happens. The patient feels lost without the support. Really, let's think about who this is coming down to. It's coming down to the patient who's actually experiencing the death. And it's an essential element of communication for that loved one, for the family. There will be a point, obviously not in every death, but in the dying process, if it's lengthy, there will be a point where the loved one won't respond anymore. And the family will need to be there to kind of express the concerns and move forward. So setting priorities in a respectful interaction. Let's talk about information sharing. What, when, how of that diagnosis. The patient has a right to this information. What's going to happen? When is it about to happen? And how is it going to happen? Some states can allow that the patients or family can read the record right from the computer with the doctor present. I'm not sure about our state. I know we all have a right to our records, but if that's information that you want to know, some will allow it. Attending to the patient's strengths and needs, whether it be a gradual diminution or quick. That's of strength, endurance, control of movement, sensory stuff. That can all go really, really fast, or it can go really slow. Some might go fast, some might go slow. It all depends on the patient and how they are responding. Talking about maintaining patients' hope with meaningful activities and a positive spirit. If you are, some of these things are attainable for your patient, these meaningful activities. If carrying on a tradition, a Christmas tradition of cinnamon buns in the morning, those kind of things, that kind of keeps up that positive spirit that your patient is looking for. And maintaining your own positive spirit in that situation, because in these times it can be challenging. Care in the right place at the right time. We talk about hospital, hospice, and home care is typically when these deaths happen. Hospital, still most die in hospitals, but hospice has become more and more equipped to kind of handle these. Hospice will focus on comfort measures when care or remission is no longer possible. At first, hospice cared for just cancer, but they are more equipped for other diagnoses now. There is home care, which is hospice without walls, basically provides hotline, care networks, or respite programs. Usually when it's home care, hospice actually comes into there just to continue the care. I hear a lot of questions about, what's palliative care? What's the difference between palliative and hospice? Well, both provides comfort. Palliative care can begin at diagnosis and at the same time as treatment. Hospice begins after treatment of the disease is stopped and it is clear that the patient will not survive. And then we're working on only comfort stuff. Essentially, it still remains the same, but hospice happens, the definition of hospice starts after the treatment of the disease is actually happening, and we're just making comfort measures. So palliative care, again, you're going to find more painkillers, morphine drips, ventilators, intervention radiology. That's sort of when that diagnosis is still happening and that treatment is still happening. And then once it is clear that the patient will not survive, hospice will start moving in. Each individual is cared for differently, so making sure that you understand that. A lot of people have trouble saying goodbye. I know that I would. The patient has to move on to that acceptance phase. And a lot of the times the patient, again, depending on the patient, will want all of their family around or not really anyone except their closest few. And that's okay. It's individualized. It's per person. Sometimes the family or patient may direct their anger about the death towards you or other members of the team. Don't take it personally. I can't imagine what they're going through or how they're dealing. But every patient, again, is going to be different. So I know that was sort of sad. That's not one of my favorite chapters, and there's a lot more. I wish we could have talked about it more in class, but if you have any questions about Chapter 12, please let me know. I'm happy to answer them for you. Otherwise, go do something happy. Thanks, guys. We'll talk to you later. Bye.